All right, if everyone can go ahead and turn your computer screens on, we'll get class started. How's everyone feeling after that exam? Are your brains fried? Feeling okay? I'm sure you guys did just fine.
That was so much.
What'd you say?
So much.
There's a lot of content on that exam, so I'm sure you guys are tired.
Oh my goodness. I've never had children, but I feel like I've had after this.
This is all you needed.
Literally.
So kind of like with the first, with exactly with like the first exam, the professors all meet and we do an exam review, to kind of go over the things that you guys missed and see, the scores and everything. We should have those scores posted for you, by like Friday night, late Friday night. Okay. So just be on the lookout for that. That's when the exams will be published because we have to wait for every class to take the exam before we can give you guys your results back. Okay. Um, so, does anyone have any questions about any of the assignments that you guys have due this week? I'm going to go over them a little bit more in detail, but just want to see if you how you guys are feeling about everything.
I know you said that we can submit a poster. Do we just take a picture of it and download it? Or, I
Yeah.
mean, or does it have to be a poster made on like electronically?
So I know there's a setting that you can do a poster in PowerPoint. Um,
Okay.
I've done one of those before. So if you can figure out how to do that, that might be easier as far as like downloading it and grading it goes. Just because if you submit a picture and it's like kind of hard to read, I'll have to like reach back out and stuff. So for the sake of just the way that this class is graded, if you can have it done electronically, that is preferred. If you're going to submit something like a poster or whatever, email me ahead of time so that I know to like be on the lookout for that. And if I have any questions, that I'm not just automatically taking points off for things that I can't see. Sorry, I think my Zoom froze there. Did you guys hear what I said?
Yeah, it froze.
Okay, let me see. I'm gonna just connect to my hotspot because this internet is being weird.
Excuse me.
Okay, can you guys hear me now?
Hmm.
Okay.
Yes.
My screen froze, so I just went ahead and switched to my hotspot. So basically, what I was saying is we prefer for it to be an electronic submission just because we want to be able to read it clearly, your teaching plan post. If you are making a poster, you're doing something along those lines, and you can't do it on PowerPoint or you don't know how, um, email me and let me know that you're going to be submitting something like that. But we'd prefer for it to be electronic just because of the way it's submitted online. Okay. So you guys have your discussion post number 3. So remember to post your initial discussion before tonight. Okay. Your first post needs to be done tonight. And then you're posting, following up on 2 of your peers' posts before Sunday at midnight. Your teaching plan will be due on Sunday. We went over that in class last week about following those guidelines that are in the assignment, including every single point that's in there. But as far as like if you want it to be a PowerPoint, if you want it to be a pamphlet, if you want it to be a poster on PowerPoint, whatever you want it to be, as you can have some creative freedom with that. Okay. You guys also have the external cephalic version assignment due by Sunday in SimChart. Okay. I keep going in to try and switch the due dates, and it keeps like reverting right back to the ones that um, were automatically uploaded. So I'm going to be meeting with Professor McBride and talking with her about that here to make sure that you guys have the correct due dates and assignments on for those sim chart in the actual sim chart. But until then, until we get it figured out, go off of your syllabus and the announcements in class and what's posted your module. Okay. Um, I let you guys.
So can I speak to that for 1 second?
Yeah.
This is an issue in all of the courses, not just in OB. When we put in the due date in the sim chart, we allow the extra week so that you guys can have the opportunity to have a late submission. Sim chart talks to Canvas, and no matter how many times we keep changing it in Canvas, it keeps reverting back. It can't we haven't found a resolution. So you guys have to follow the syllabus, and then Professor Young has done a good job of telling you guys every week, this is what is due, this is what is due. So do not go by what that says. Remember, it has the extra week built into it. Okay, and so you're still responsible for your due dates that are posted in the syllabus. We had a whole meeting about it this week, and it's just, she's frozen again. We had a whole meeting about it this week, and we haven't found a fix. Okay, I don't know, Professor Young, if you heard what I said because your
Yeah,
internet cut out.
I heard you. Yep.
Okay. So go by the due date in the syllabus, and then she's doing a good job reminding you in your announcements every week what's due. Okay, so go by that. Remember, SimChart has the extra week built in for the late when it shows your due date that's flowing over.
All right. Thank you. The last thing I really want to talk to you guys about is what we can expect for next week. So next week we're going to have quiz number 5. That's the last quiz that we have in the class. Okay, last quiz. Woo, exciting stuff. So come on time to class, just like we've been doing the whole semester. We're going to start that quiz right away. So if you guys are not in class to get the access code for the quiz, you will not be allowed to take the quiz. And I do not want that to happen for you just because we're getting towards the end and I know every point is going to matter here. Okay, so make sure you're here on time for the quiz. Keep an eye out for my welcome to week 8 announcement on Saturday because you guys do have a decent amount of things due next week as well. So I don't want to be overloading your brain by telling you every single thing right now, where we're going to focus on week 7 and then just pay attention to the announcement this Saturday, which will be giving you guys more detail about the assignments that are due next week. Okay. I wanted to go over the teaching plan with you guys last week just because it is a little bit different and it's a bigger project. So I wanted you guys to be able to ask any questions that you may have about that. Okay. I still have a lot of time available on my calendar if you guys want to meet with me. Okay. Just send me an email or shoot me a message on Canvas, especially if after this exam you're unhappy with your exam 2 grade. Okay. I'll want to meet with you. To discuss ways that we can improve your studying techniques, what you should be focusing on a little bit more going into exam 3 and our HESI exam at the end of the term. Okay, so my availability is pretty open during the weeks, so just don't hesitate to reach out if you have any questions or if you want to meet with me. Okay, I'd be happy to meet with all of you. So we are moving on. I know you guys really enjoyed talking about labor and pathophys of labor and all the meds and all that good stuff. We're now moving on to talking about newborns. So today we're going to be focusing on newborn head to toe, and we're also going to be talking about like care of the newborn and family immediately after deliveries and stuff. Okay, this presentation that I have, I uploaded into your Canvas. We are going to try and get through all of it, but I'm going to just preface that by saying this is a lot of content and this stuff is going to be needed to be reviewed by you guys individually as well, because I'm not sure if we're going to be able to make it through the entire presentation. We're going to try our best. But if we do not, definitely you need to review the chapters in your textbook, as well as the slideshow and the presentation that I have for you in Canvas. Okay. So I'm going to pull that up here. Just give me a second because my computer is being real slow, and we'll get started. All right, can everyone see my screen? Awesome. So before we get started, I need January you to turn on your camera.
My camera is on. This thing said I'm in driving mode and I'm sitting right here at my desk. I can see you all.
Yeah, for some reason I'm not able to see you on your Zoom. So if you want to try and go out and come back in and see if there's like a mode that you're in or something that's putting you in that, I just need to be able to see you. And then same with Tamikia, if you can just kind of make your screen able to see you guys. If everyone can just make sure you guys are in your screen, that will be very helpful. Thank you. And then Jade, I think your thing reset to say Zoom user instead of your first and last name. If you wouldn't mind just changing that for me real quick. Please.
Can you see me now?
Let me see. Yep, I can see you.
Okay.
Thank you.
You're welcome.
All right, everybody, bear with me here. I know you're tired, but we're going to get through this PowerPoint here. We're going to talk about the newborn, nursing care of the newborn and the family. Okay, so as you guys know, there's a lot of things that are happening as the baby is transitioning from life inside the womb and in utero to extrauterine life. Okay, the baby's from a pathophysiological standpoint, there's a lot of different things that are going on inside that newborn body and their system that make them compatible with life and make the transition to life easier. So we're defining the neonatal period as from birth to 28 days of life. What kind of adjustments are being made by the infant at this time? They have to establish and maintain respirations, right? Because in utero, their lungs they're not breathing the way that they are going to be extrauterine. They're going to adjust circulatory changes, regulating their temperature. They're going to be trying to maintain their nutritional value, digesting nutrients, eliminating waste, regulating their weight. So they're doing a lot of different things in this first 28 days of life that they haven't had to do up until now. As far as behavior adjustments, they're going to be establishing a regular behavioral tempo. They're going to be processing and storing multiple stimuli because if you think about it, they're not really getting very much stimuli in utero. And then the second they're born into the world, they're having sight, smells, taste, sound, hear, all the things. So that's going to be a major adjustment for this newborn. And then they're going to be establishing a relationship with the caregivers and their environment. Let me try and zoom in on this, make it a little bit bigger for you guys. There. Okay, there are different stages of newborn transition, not transmission. Huh. So the major adaptations that occur after birth during the first 6 to 8 hours. Okay, it's mediated by the sympathetic nervous system. This results in changes that involve heart rate, respirations, temperature, and GI function. So there were three big guys that proposed 3 stages of newborn transition. Their last names were Desmond, Rudolph, and then the last one I can't really say. It's spelled out for you in your textbook. So the first stage is what is called the first period of reactivity. It lasts up to 30 minutes after birth. And what is happening in this stage? The newborn's heart rate is going to increase rapidly to about 160, 180 beats per minute, but then it'll gradually fall after 30 minutes to a baseline about 100 to 120. Their breathing pattern is going to be irregular with a rate between like 60 to 80 respirations per minute. Their lungs are not going to be super clear because if you think about it, as they're coming down the vaginal canal, they're ingesting a lot of amniotic fluid, a lot of fluid from labor. So they're going to have swallowed a bunch of stuff. So hearing some crackles initially when a baby is born is not concerning. We only are concerned with that if they are displaying other signs of respiratory distress, which we'll talk about here in a little bit. If baby might be grunting, they might have some nasal flaring and retractions, but those should cease within the first hour after birth. Typically, the infant is alert. They may have a startle response. They're crying. Their head is going to be moving. They might pass their first meconium in this stage. Okay, so this is we're talking about immediately after this baby is born, what this infant is going to look like. Their second stage is called the decreased responsiveness stage, and this lasts from about 60 to 90 minutes following the first stage. And in this stage, the newborn is sleepy, okay, or they have a decreased amount of motor activity. So they are on this immediate high where their heart rate and everything is really elevated. They're crying, they're welcome to life, super shocked, and then they go into this like sleepy stage. They're going to be pink. They should not be like acrocyanotic really at this point or have any like blueness in their mouth or anything like that. Respirations are going to be pretty fast, shallow, and unlabored. Okay, that's a normal thing that we're going to anticipate to see in that stage. And then finally, this third stage is called the second period of reactivity. This is going to be brief periods of tachycardia and tachypnea associated with the increased muscle tone. They're going to have a little bit of changes in skin color and some mucus production. So they're working up all that stuff that they swallowed whenever they were born, right? So they're trying to get rid of all that mucus and all the stuff that they ingested during delivery. Meconium is usually passed at this time if it had not been passed previously. One thing to note though is that preterm infants may not experience this transition, this exact first, second, and third stage transition, because their body systems are not as mature, right? So their first stage where they're having like that grunting, they're having difficulty breathing, they're having the retractions, that is going to last a lot longer for a preterm infant than it's going to for a term infant. Okay, so that's something whenever like you're reading a question on a test, or if you're a labor and delivery nurse or you're at clinical and you know like, all right, we're having a 34-week baby. They are not going to transition to extrauterine life the exact same way that even a 36-week baby is going to, because their muscle tone and their lung development is not as mature as a term infant. So those are some things that we want to know going into a delivery is what is this infant's gestational age and how is that going to affect the things that we're preparing for as their nurse at the bedside whenever they're first being born. So we're going to go into depth into each different system. I'm not going to spend a bunch of time on these because most of the stuff that I want you to know is written out for you on these slides. Okay. There's not really a whole lot of things that I'm going to go in detail with. We are going to go in depth on the respiratory and the cardiovascular system, but the other systems I'm going to let you guys kind of review on your own because there's not that much extra to talk about in those slides. Okay. So, what is our goal with the infant respiratory system? Obviously, we want them to establish effective respirations. Okay. This might to us be like, oh, okay, whatever. But for a newborn who's not used to breathing, there are a lot of different things that have to happen within the body during the labor process and then following that is going to help the system be developed and help them have these effective respirations. Okay. So we're going to talk about chemical factors. Okay. So, there is going to be a big shift in this neonatal system. So, activation on the chemoreceptors in the carotid arteries and aorta are going to result from a relative state of hypoxia, which is associated during labor. Okay. So, there's going to be chemoreceptors that are stimulated just because of the limited amount of oxygen that the infant is going to be receiving during labor. Which, with each labor contraction, there's a temporary decrease in uterine blood flow and transplacental gas exchange, which results in fetal hypoxia and hypercapnia, right? So every time that uterus is contracting, there's going to be a limited amount of blood flow, thereby a limited amount of oxygen being delivered to that infant. Okay, so these decreased levels of oxygen and the increased amount of carbon dioxide have an effect that is going to ultimately initiate neonatal breathing by stimulating their respiratory center in the medulla. This does not mean that the baby is taking its first breaths before it's even born. That's not true. But the way that labor is working on the baby is preparing the baby to transition to being able to taking their first breaths whenever they are out of utero and they're born and they're in the air and they're having to regulate their own oxygen consumption. Okay. So by decreasing the oxygen amount during labor, it's actually getting that infant ready to take their first breaths when they are born. Okay. Another chemical factor may also play a role. So it is thought that as a result of clamping the cord, there's a drop in the levels of prostaglandin that can inhibit respiration. So whenever we cut that cord, it will limit the amount of prostaglandin that's being released to that infant. That's going to stop them from taking breaths. Okay, so even cutting the cord, releasing the baby from mom itself is going to help stimulate that respiratory effort. So for some mechanical factors, respirations in newborn can be stimulated by changes in intrathoracic pressure, and this results from compression of the chest during a vaginal birth. So as that baby is passing through the birth canal, the chest is being compressed, right? With every contraction, there's that squeezing motion that's on the baby. With birth, that pressure on the chest is released, and the negative intrathoracic pressure helps to draw air into the lungs. Okay. This also is going to increase distribution of air in the lungs, and it's going to promote the expansion of their alveoli. And then crying is going to keep the alveoli open. Right? So that compression that they're getting on their chest is kind of like getting their body ready to, in turn, expand and take that first big breath and first big cry of life. Okay. That's why if you guys have had a delivery in your clinical, or if you've had a baby or you've been in on other deliveries, like everybody gets so like, you can feel like the room kind of relax when that baby takes that first cry, because that's basically telling us like that baby is moving air, right? That baby is moving oxygen, and their physiological system is starting to take place once they're delivered. Okay. So let's see here. Some thermal factors. So the baby is going to be entering a lower temperature environment, which is going to stimulate the skin receptors and stimulate the respiratory center in the medulla. So that's basically like you guys getting in a cold plunge and like feeling that shock to your system, that's basically what the baby is experiencing. Okay. They're going to have this external stimuli that is hitting their skin that is causing them to be like, oh man, what just happened? And then cry and start the respiratory system. Okay. Some sensory factors. So if they're being handled by physician or healthcare staff, like we're drying them off, we're rubbing them, we're rubbing their feet, we're rubbing their bodies, we're suctioning out their mouth and nose, and then just being overall introduced to that external environment, that is going to cause the baby to cry, and that's going to stimulate their respiratory system as well. Okay. And then the last thing we're going to talk about in this section would be establishing respiration. Okay. So the alveoli of the term infant's lungs are lined with surfactant. Okay. Surfactant is a huge thing that I want you guys really to understand whenever we're talking about fetal lung development, as well as its role in the respiratory system itself. Okay. Surfactant is one of those things that preterm newborns do not necessarily have whenever they are born, and that is what causes them to have such difficulty with respiratory effort. Okay, so surfactant is a lipoprotein that is manufactured in lung cells. Lung expansion depends largely on chest wall contractions and adequate secretion. So what does the surfactant do? Surfactant lowers surface tension, and then it reduces the pressure required to keep the alveoli open with inspiration. So that is going to prevent these alveoli from collapsing, right? So that is going to maintain your alveoli. So your surfactant is really important in making sure those alveoli stay open so that babies can have adequate gas exchange, right? So without surfactant, more pressure must be generated for inspiration, which babies are going to soon tire or exhaust from that. So if they don't have enough surfactant, it is going to be much harder for them to breathe because they're working really hard just to keep those alveoli open, just to maintain inspiration and expiration, that they're going to just burn out. And that's when you see babies that are like breathing super, super fast. They have those retractions. They're compensating. That's a compensatory mechanism for these infants that ultimately just need more surfactant to help with the smooth transition of inspiration and expiration in the lungs. That is kind of a big point when we're talking about the respiratory system. Do you guys have questions about that? Because I really want to make sure you guys understand that part. Okay. So at first, your breaths are going to be shallow or regular and include some pauses. Babies are naturally or nose breathers, and this is what enhances their ability to just suck, swallow, and breathe. Okay. If babies were mouth breathers, that would not bode very well for breastfeeding or for feeding in general. So their breath sounds should be clear or equal bilaterally. And like I said, if they're having a little bit of grunting or respirations in that first transition period, that is okay. We just want to make sure that stops and where it's not continuing. Because if it's continuing, then we have something else that's going on. Like respiratory distress. Okay. I want you guys to know this slide for sure. The signs and symptoms of a newborn respiratory distress. They're going to have those nasal flaring, intercostal or subcostal retractions, grunting, more retractions with some stridor, seesawing of paradoxic respirations. If their respiratory rate is less than 30 or greater than 60, and know what is going to cause tachypnea versus like why is an infant going to have higher respirations, right? They could be trying really hard to get the meconium out of their lungs or get any fluid out of their lungs. Respiratory distress is going to cause tachypnea. If they have any type of infection, that is going to be something that'll cause tachypnea. And then any change in color. So if they are acrocyanotic in the first 24 hours, which means their body is pink, but their hands and their feet are blue, that is okay. But if it's over 24 hours and they're still like their whole body isn't completely pink, we're going to be a little bit like concerned about that. And we need to do some additional testing and see what's going on. Okay. So I really like this slide. I stole it from Professor McBride. So this mnemonic here, wet frog, is a good way for you guys to remember signs and symptoms of respiratory distress. Okay. Your baby's wheezing, they have high effort of breathing. So those like retractions would be a sign of that. Tachypnea, nasal flaring, oxygenation, and any grunting. I included this video here for you guys to look at because we can say like, oh, the baby, if they're wheezing or if they have nasal flaring, but you guys may not know what that looks like or what that sounds like. So this video kind of shows you what an expiratory wheeze, retractions, and tachypnea in a newborn is going to look and sound like. So I want you guys to take a peek at that too, because I think that'll be really helpful in you understanding what does a normal baby look like when they're breathing versus a baby that's in respiratory distress, especially for people who don't have babies yet or haven't seen babies that are actively in respiratory distress. Okay, moving on to our cardiovascular system. Okay, lots of changes are going to be happening in this system as well. The cardiovascular and the respiratory systems, as far as your physiologic adaptations for newborns, are the most important things that you guys need to remember and need to understand. Okay, so one of the major things is that there's going to be the closure of the foramen ovale. I never know how to say that word. I should know by now. I've seen it millions and millions of times. So there's going to be increased pulmonary blood flow from the left side of the heart, which is going to increase pressure in the left atrium. So it's going to cause that to close. Okay. There's also going to be that constriction of the ductus arteriosus. In a term infant, this is going to close in 24 hours, and then it'll permanently close within 2 to 3 months. It can reopen in response to low oxygen levels. So if a baby has a murmur, right? You listen with your stethoscope, you hear baby has a murmur. Something that can cause that is if that ductus arteriosus is remaining open. Okay. So we're not really going to do too much for a newborn that has a murmur at that time. We're going to report that to the pediatric provider and let them keep an eye on it, and that baby is going to be monitored very closely. Okay. All right, let's see. What else do I want to say about that? Whenever the cord is clamped and severed, so the umbilical arteries and the umbilical vein and the ductus venosus are functionally closed and are converted to ligaments within 2 to 3 months. Okay. So those three things are going to cause that cardiovascular system to change from being regulated between placental, maternal, and fetal blood flow to just regulating fetal blood system, right? Because they're going to be their independent body system after birth. Once they're cut from that umbilical cord, they're going to be regulating their own blood flow and moving the blood through their own body, right? So we need to know what our normals are. Our normal heart rate is 120 to 160 beats per minute. It's okay if it drops a little when the baby is sleeping. We need to listen to an apical pulse for a full minute on a newborn whenever you're doing an assessment. And that is because we want to be able to listen for heart murmurs, any other type of irregular arrhythmias. And we need to be able to listen for a full minute to accurately count fetal pulse. The only time I don't listen to a newborn's full heart rate for a minute when I'm doing a head to toe assessment is just that immediate newborn transition period where babies are right after birth. Like you just are going to listen for 6 seconds, multiply that by 10 or however you want to calculate it whenever you're trying to just get a quick heart rate to make sure that baby is stable. The point of maximum impulse is in that fourth intercostal space left to the midclavicular line. That's where you're going to listen for the full minute. And then other things is like, when are we going to see fetal tachycardia? When are we going to see fetal bradycardia, right? Tachycardia could be with respiratory distress. It could also be with infection. Bradycardia, we're a little bit more concerned about with this at this stage in the game whenever babies are first born, because that could mean that the baby is not transitioning very well into extrauterine life and may require some initial intervention at delivery to help bring that heart rate up. Whether that's positive pressure ventilation, we're going to get that more into that next week whenever we're talking about newborn resuscitation. Okay, we'll kind of go through that a little bit more in depth. I kind of mentioned murmurs already, but this is going to be an irregular heart rate, and it is going to be common in the first few hours. That especially if that ductus arteriosus is remaining open. They usually have no significance, and they self-correct in 6 months. Sometimes, if mom or dad have a cardio history, we're going to be getting like echoes and stuff in utero. But that might be something we need to follow up with a little bit more closely, especially if there's a family history of murmurs or other type of cardiovascular defects. So I'm sure you guys have seen a whole bunch of stuff about delayed cord clamping. Okay, this might be something you experienced whenever you were having your own children, or even just as a bedside nurse, seeing moms really prefer this and request this. Delayed cord clamping is huge, okay, because it helps increase blood volume and the blood pressure in a baby initially, okay? It also reduces the risk for intraventricular hemorrhage and necrotizing enterocolitis. This is very important, especially for preterm infants. If the infant is stable and can remain on mom for the amount of time it takes for that cord to turn white, or for the 3-minute period that we give them for like the delayed cord clamping, okay? If your baby is not stable, unfortunately, getting that cord clamped and getting the baby over to the warmer is more important than getting them cord blood. Okay, we just kind of mentioned that it's very important for babies to get cord blood, especially preterm, because it can help increase that blood volume and their blood pressure. Polycythemia can occur. The biggest thing about that is that it just increases a baby's risk for hyperbilirubinemia, which could be that jaundice, that yellowing of the skin, yellowing of the eyes, that kind of stuff. But overall, delayed cord clamping is amazing. That's why we encourage every mom to do it. Most providers are really good about doing it as well. So it's always something to keep in the back of our minds. So, signs of cardiac defects would be dyspnea or apnea, cyanosis, pallor, poor feeding, unusual or absent pulses. Okay. Okay. The thermogenic system is another big one we talk about when we talk about babies, because babies have a really hard time regulating their own temperature. Okay. That is why we need to be really proactive as nurses with educating moms on keep your babies away from the vents, keep them away from drafty windows. If it's 95 degrees outside, maybe don't put them in their winter coat. You know what I'm saying? So, like, these are things that we need moms to be aware of, that babies are not able to thermoregulate the way that adults can. Okay. Skin to skin is huge with thermoregulation, and especially in the immediate postpartum period. Okay. Putting a baby skin to skin is immediately going to help them match their body temperature to the temperature of mom's. It's going to regulate their nervous system. It's going to increase their heart rate, their respiratory rate. Skin to skin immediately after delivery is humongous, and it's something that every infant should be able to do, or should be doing, in the immediate postpartum period, unless we are doing resuscitation on this infant. So hypothermia from excessive heat loss is common. And then we want to talk about how heat is lost in infants. When you guys are studying for exam 3, I would definitely know the differences in these types of heat loss and examples of them. Okay, I think that would be a really important thing to study if I were you. So one that we're going to talk about is convection. This is the flow of heat from body surface to ambient air. So what are some ways we can prevent this in babies? We're going to wrap them up and swaddle them, put on a hat, and then decrease the amount of exposed skin. Radiation is loss of heat to a cooler solid surface in close proximity, so that's that keeping them away from windows and drafts, putting them skin to skin to increase the temperature of their own skin, and just maintaining them, keeping them away from like vents and cool, or like fans. So like a lot of women will want a fan in labor. And whenever like a baby is first born and put up skin to skin, we need to make sure we turn the fans off in the room, because babies lose heat really, really quickly. So that is something to keep in mind as the bedside nurse. Evaporation is loss of heat when liquid is converted to vapor. So we need to dry the newborn when they're born, remove wet blankets. Whenever you're giving a baby a bath, we're doing it under the radiant warmer to prevent excessive heat loss. We're getting a temperature before and after the bath to make sure they didn't lose too much body temperature during the bath, and leaving them under that radiant warmer for a couple of minutes afterwards. And then the last one is conduction. This is loss of heat to cooler surface in the direct contact. So having a pre-warmed bed or warm blankets, making sure you use a warm stethoscope. Babies are just really sensitive with everything that has to do with thermoregulation. So just keeping that in mind, and I would definitely know those 4 different things. Okay, so when we're talking about thermoregulation, we also have to talk about thermogenesis. So in response to a cold, the neonate is going to attempt to generate heat by increasing muscle activity. So they may cry and appear restless. They may be like moving their arms and legs and stuff really fast. But in order to conserve heat, some infants are going to assume a position of flexion, which is going to guard against their heat loss. So as like a nurse, like if I see a baby's like in a bassinet without any shirt or anything on, it's kind of cold in the room, they're crying, they're not very comfortable, we need to get them warm, put them skin to skin with mom or cover them up. So non-shivering thermogenesis, so like in adults, right, whenever you're cold you shiver. That is something that your body is doing to try and get your body to regulate some more heat and increase your overall temperature. Babies aren't going to be shivering. That is not something that babies do. If you see a baby shivering, it's probably jittery from like low blood sugar or something else is happening. So babies are not going to be shivering the same way adults do. This is an alternative way that infants produce heat. It is only triggered when their skin temperature decreases to under 95 degrees Fahrenheit. This is what happens when babies start using they metabolize their brown fat. So reserves of brown fat are rapidly depleted with cold stress. So I put this picture over here because I wanted to show you guys where brown fat deposits are in infants. And also like they only have a certain amount of those brown fat stores whenever they're first born, and they slowly will increase, but not at a rate that is going to prevent them from getting like burning through those reserves, right? We do not want infants to burn through those brown fat reserves because then they're compensatory mechanism against like being cold is not gonna work anymore if they burn through all of those stores of their brown fat. So we need to make sure that we're keeping babies nice and warm. Okay. So hypothermia and cold stress. So if hypothermia is not corrected, it's going to progress to cold stress. And this is what happens when an infant is going to appear like pale and mottled. Their skin's going to feel really cold. Their respiratory rate is going to increase in response to the need for oxygen. And then they're going to have some respiratory distress as a result. So if a baby gets too cold, that's going to put them at a risk for respiratory distress. Okay, so you guys need to definitely know that. And then what's going to happen to their metabolic system? So their basal metabolic rate is going to increase with cold stress. If cold stress is protracted, their anaerobic glucolysis occurs. So that is going to result in an increased production of acids. So your metabolic acidosis is going to develop. And if there's a defect in respiratory function, respiratory acidosis is also going to develop. So excessive fatty acids can displace bilirubin from the albumin, and that might also cause hyperbilirubinemia. Okay, hypoglycemia is another metabolic consequence of cold stress. So all of these things can happen as a result of the baby being too cold. They could be in metabolic acidosis, respiratory acidosis. Their blood sugar is going to drop because all these compensatory mechanisms are working really hard to bring their body temperatures back up. So they're going to burn through all their reserves. So we really want to make sure that these babies are staying warm because they do not regulate their own temperature very well at all. And it's going to lead to a lot of other problems. So when we talk about babies being too cold, we also have to talk about babies being too warm. This occurs less frequently. It's defined as when the baby's body temp increases over 99.5 degrees Fahrenheit. Some causes would be like sepsis or another infection. Or if parents are, if we're using an inappropriate external heat source. So if a radiant warmer is on too high, if we're giving phototherapy for a baby having too high bilirubin levels, they can get really hot from the phototherapy. If a baby's outside for prolonged periods of time. I know this was a huge thing I had to talk about with Amish patients because the Amish don't have air conditioning, right? So we need to educate these certain types of patient populations on if it is 90 degrees outside, your baby does not have to have 20 different layers on. Okay. The good rule of thumb is if you're cold, your baby's cold. If you're hot, your baby is hot. So adjust them accordingly, monitor them accordingly. So some clinical manifestations would be baby's skin is going to be pretty flushed. Their hands and feet will be warm. They're going to have that posture of extension because they're just like they're overheating and they don't want to be too curled up and too compacted. All right. So for the renal system, I don't really have anything else to add besides what is present here on your slide. We're running pretty short on time here, so I want to get to, let me see. I really want to talk about the gestational system, which is next. Okay, so the biggest thing with your renal system is we want to be monitoring baby intake and output, right? If babies haven't peed within 12 hours, we need to notify providers. The GI system has a little bit more of variance that can happen and some other things that can occur. So I want to go over this one in a little bit more detail. So normal findings in a term infant, they're going to have pink and moist mucous membranes in the mouth. Their palates are intact. Mucus can be common. Epstein pearls are okay. And the baby's cheeks are going to be pretty full. So their feeding behavior, preterm infants have difficulty with breastfeeding because the sucking and swallowing reflexes are not yet fully developed. The sucking and swallowing reflex are typically present in 32 to 34 weeks of gestation, and they're not well developed until about 36 weeks of gestation. It is normal for sucking to take place in small bursts, about 3 or 4, and up to 8 to 10 sucks at a time, with little pauses between them. The neonate is unable to move food from the lips to the pharynx, so therefore we have to make sure that the baby has a good latch where the nipple is being placed very far inside the baby's mouth, because they're not able to move that colostrum or that milk back on their own. So that's why making sure they have a good latch is super important. Okay. See, their teeth are going to begin developing in utero. If a baby is born with a tooth, that's something that we have to mark on our assessment. I personally have never seen it, but it does happen every now and then. So intestinal flora, infants born vaginally appear to be initially colonized by the mom's vaginal microbes. So when babies pass down through the vaginal canal, they're absorbing some of those vaginal microbes, which can increase the amount of intestinal flora that they're born with. So this is different than a baby that's born by C-section, where they're first colonized by maternal skin, so being skin to skin. Breastfeeding is super important in establishing the intestinal microbiome, okay? Because human milk is going to contain a large variety of microbes that originate in the mom's GI tract. Okay, that's why we talk about breastfeeding being so important, because they contain a lot of those microbes that are going to be important for infants' gestation and intestinal development. And then let's see here. As far as stomach capacity, baby's stomach capacity will vary widely just depending on the size of the baby and gestational age. So after birth, the stomach becomes increasingly more compliant and can relax and stretch to accommodate larger volumes. But these volumes that I have listed here are pretty much the targets for day 1, 3, and 7. So you can see babies on the first day really do not need very much as far as intake goes. 10 mLs is enough to completely fill their stomach. Okay. And then it grows as they get older. So spitting up is normal. It can be avoided by not overfeeding, and we want to encourage parents to burp after every feed, sometimes multiple times in between feeds, just to make sure that babies are not running into that esophageal reflex, that GERD, and vomiting up their food. So some stools, this is also what I want you guys to know as well. Infant stool is going to change appearance based on the baby's age and also their intake. So meconium is the baby's first stool. It's that dark, tarry, thick substance that babies pass shortly after birth. Sometimes they pass in utero, which we run the risk of meconium aspiration, right? Meconium contains that occult blood. That's why it's so thick and dark and tarry. Transitional stools usually appear by the third day after babies start feeding. It's greenish brown to like a yellowish brown. It's thin, it's less sticky than meconium. And then finally, we have milk stool. So this is different based on basically what the baby is nursing with, right? If baby is being breastfed, it's going to be a yellow to golden consistency that'll resemble a mixture of mustard and cottage cheese. It looks kind of weird, but that is normal. For a formula fed baby, it's going to be more pale yellow to light brown. It'll have a little bit firmer of consistency, and it's going to smell much stronger. Okay. And then for our signs and symptoms of like problems with the GI system, we're worried about decreased stool output. If a baby's, if a baby's belly gets really firm and hard, or their bowel sounds are absent, or even like hyperactive and they're not passing gas and they're not having any stools, that is something that we start to get nervous about. Okay. We're worried about with like if you have a baby who's not pooping and who's throwing up all their feeds, what do we worry about with that? What would you think as their nurse?
Dehydration.
Could be dehydration. What else? Like the big scary.
Intracranial pressure.
Not necessarily. We're worried about what? Like we're worried about that system being blocked. So like a bowel obstruction.
Okay. That was my next choice.
Yeah, bowel obstruction. If your baby isn't pooping and they're throwing up all their feeds, there must be like some type of obstruction somewhere. So that is why we keep really close eye on stools, especially in that first 24 to 48 period. We educate parents really heavily on that when they go home. Okay, this slide here, I have a picture of what the different stool colors can look like. What are things that we worry about versus what is normal? I have a picture up there too of those Epstein pearls that I mentioned. They're alongside a picture of baby teeth, and then a normal like feeding chart, what babies should be getting. Okay, let me go through and see what else I really want to hit on here. We do want to talk about the hepatic system because that's when we're starting to talk about bilirubin. Okay. So baby's liver, the liver is super important, obviously, just in general, but in the infants, plays a major role. So it stores iron. Their iron storage, they have enough, they're born with enough to last them 4 months. The liver is also responsible for glucose homeostasis. Okay. Initially, their glucose levels are going to drop 30 to 90 minutes after birth. That's why we have them initiate feeds within that first hour, because we want their blood sugar to come up. Signs and symptoms of hypoglycemia. I would star, circle, bold, highlight this entire little paragraph here. The signs and symptoms of hypoglycemia. You guys are going to want to know that for sure. Babies are going to be super jittery, where they're like kind of like shaky, they're overly startling. They might be super lethargic. They might have periods of apnea, feeding problems, and eventually, if we let hypoglycemia progress, it can get to the level of infant having seizures. Okay. If a baby has persistent hypoglycemia, we need to intervene with some pharmacological intervention. That would be like oral glucose gel. Okay. Because hypoglycemia and hypothermia in babies, those are emergencies and need to be dealt with very quickly because babies can't regulate these things on their own super well because everything is so immature still, right? The liver is also responsible for fatty acid metabolism, which is a major source of energy for the infant. And then the other thing it regulates is coagulation factors. So these are synthesized in the liver. They're activated by vitamin K. The lack of intestinal bacteria is needed to synthesize vitamin K results in transient blood coagulation deficiency between the second and fifth day of life. So babies are not producing their own vitamin K immediately. That is why it's important that we administer that vitamin K injection at birth to prevent that the vitamin K deficiency bleeding. This type of bleed can occur suddenly and be catastrophic. Okay. So like recently, I know like at least at my hospital, I've had a lot of patients who have been refusing vitamin K injections for their infants. It is a personal choice. It is something that is up to the mom, that is up to the parents, whatever they decide. But you need to educate them as their nurse and say, like, okay, well, if your baby were to get bumped or God forbid dropped, or there's a sibling at home that like bumps their head or something, that baby is at a higher risk for bleeds because they don't have that clotting factor yet. That is why that vitamin K injection is so important. Physicians will not perform a circumcision on a baby unless that baby has received vitamin K. So we need to also tell them about that. Okay. So unfortunately, let me see.
So how do you get around that? Because I've known people that don't get the shot and still get circumcised.
So
Not babies.
So most of the providers I work with will refuse, and they'll have the baby come back in a week whenever they are doing their own whenever they are producing their own vitamin K. So it's usually just delayed. Because babies don't have to be circumcised like within the first 24 hours. Most people just do it then because of the convenience. You're already in the hospital. But if they do refuse that vitamin K, we just tell them to come back and schedule it outpatient. But all right, so next week, the PowerPoint for week 8 is not as long and detailed as this one is. So we can go over some other like the big points from this week, but until then, I want you guys to review this PowerPoint pretty in depth. And most of the stuff that I want you guys to know is already written on it. I don't have very many like questions written in, you know what I'm saying? But we'll try to review big points next week too from this week. Okay. So if anyone has any questions, you guys can stay after class for a little bit. But if not, I'll see you guys next week. Okay. Email me with any questions.